Sounds good. So, for those of you who don't know me, I'm Jackie Ostro. I'm a hematologist based out of Scarborough General Hospital, and I have the pleasure of introducing today's presentation. So it will be given by Evan Pakitis and Paul Kafantaris from the Hospital Liaison Committee for Jehovah's Witnesses. So I've been assisting in providing hematologic consultations for patients who are Jehovah's Witness for years, especially when they come into hospital with severe anemia or need optimization preoperatively, but only have heard more recently about how the Hospital Liaison Committee can really help our patients. So I think this is an extremely valuable service, and it can help bridge the gap between the physicians and the patients in order to provide patients who are Jehovah's Witnesses with the best possible care in keeping with their beliefs and their wishes. So I want to thank Evan and Paul for being here today and for providing us with an update on evidence-based strategies for bloodless care and how we can use the Hospital Liaison Committee to help our patients. Thank you.
Thank you very much, Dr. Ostro. Well, I'd like to introduce myself. My name is Paul Kafantaris. I and my family live in the Scarborough area for the past 20 years. I have recently retired from the post office, and it's a good thing during these days, cold days. I feel for those that work outside, like I was delivering mail. I currently serve in the community as a volunteer minister of Jehovah's Witnesses. And I will allow Evan to introduce himself.
Hello, everyone. My name is Evan Pakidis, and yes, you guessed right, I am Greek. From my accent, you can tell that I moved recently in Canada. Actually, I'm from a very sunny island of Greece, so what am I doing here in Canada in -20? There is no answer for this. In terms of work, I've worked in hospitality services and construction many years, but my last job was in a school for clients in the spectrum, in the operations department. If you meet me in person, which I would love, by the way, don't bother to ask me anything about Blue Jays. I have no clue about baseball. But if you want to make a perfect tzatziki or souvlaki, I will be happy to help you. Together, today we will review briefly some transfusion alternative strategies and the resources available for you. And it's normal after the presentation to have questions. So please take a note, and we'll be happy to discuss these questions at the end of the presentation. Actually, for that, we have also Rosie with us, who will assist us, and I will let her introduce herself. Rosie?
Thank you, Evan. So my name is Rosie Gilby. I'm a surgical nurse and have been for over 30 years. I work at the hospital in Barrie, Royal Victoria Hospital, and I have the pleasure of being part of the HLC team in being able to have some practical insight on the ground as to how this works, both from a hospital viewpoint, but also from a patient viewpoint. So I'm very happy to be here today. And if there's any questions, I'd love to be able to be part of the answer. Next, we'll have John introduce himself as well as part of our team.
Good afternoon, everyone. It's a pleasure to be here. My name is John Humphreys. I'm a volunteer with the Hospital Liaison Committee team and have been for the past 25 years. I was born in Scarborough at the Scarborough General Hospital. It was part of the York County back in those days, almost 68 years ago. And retired from the city of Toronto, worked there for many years, and have enjoyed serving hospitals through the HLC network in the east part of Toronto for the past 25 years, and have had tremendous experiences with the Scarborough Healthcare Network, the 3 hospitals, and look forward to continuing to liaison with the medical community in the hospital network. Thank you.
So once again, thank you for joining us for today's education rounds. And the presentation is entitled Medical Management of Jehovah's Witnesses, a collaborative approach. And we'll start off by telling you of a story about a recent experience with a patient at Scarborough General Hospital, an elderly witness patient who was admitted with internal bleeding. Due to her condition, surgery was ruled out as too risky. However, her condition deteriorated to the point that she was moved into the intensive care unit. However, with collaboration with the patient blood management department and the hospital liaison committee, she was given tranexamic acid and fibrinogen. Her condition improved to the point that after some days, she was discharged from the hospital. So this highlights our first key point. We all want the best medical care for our families, Jehovah's Witnesses included. We cherish our lives and go to great lengths to find the best care. We recognize, though, that requesting bloodless management can be a challenge that we are happy to say that the Scarborough Health Network team is successfully meeting head on. On behalf of the Jehovah's Witnesses community that have come through your doors, thank you very much for treating them with dignity and care. But have you at times felt like this? Like doctors and patients who are Jehovah's Witnesses are on different sides of the treatment spectrum? Families might wonder if their doctor will misunderstand their view on blood, thinking that they don't want to be treated. Doctors, on the other hand, might struggle to navigate all bloodless options available and to be able to explain it in a way that patients will understand. So what is a solution? Well, let's build a bridge. This presentation is going to equip everyone with information needed to bridge the gap and collaborate. And we will discuss 3 keys to the collaborative approach. These 3 keys include understanding our position. For example, what is our position on medical treatment? Second key, implementing strategies to avoid blood transfusion. What are these strategies? And how can we collaborate to find evidence-based solutions? And the third key, utilizing our network. What is this network? And how can it make your job easier? So let's start off with our first key, our position. And Evan will go over this part.
Thank you, Paul. You might have wondered why some treatments are unacceptable to Jehovah's Witnesses as a whole. Perhaps you have heard that some witness patients accept some treatments, but others do not. Well, this section will answer those questions and will explain our viewing certain medical treatments. We'll also explain our religious and ethical position regarding medical care, but promise without turning this presentation to a religious one. As you see in this quote, we as Jehovah's Witnesses seek the best medical care possible. We do value life and we do desire quality medical care, absolutely, but without blood transfusions. So how do we value life when seeking medical treatment? For example, we have no reservations about visiting hospitals when necessary. We ourselves are patients of Scarborough hospitals. We value the advice of health care professionals, and we take the medication that is prescribed to us. For example, during the recent COVID-19 pandemic, some might have thought that Jehovah's Witnesses are opposed to taking the COVID-19 vaccination. However, we can say that by far the majority of Jehovah's Witnesses took the COVID-19 vaccine. For the next minute, for you to understand clearly why we refuse blood, it is important to explain very briefly our Bible-based reason for refusal. But again, I want to assure you that it's not a religious presentation. So here in your screen, you see a Bible verse in Acts 15:20, where it says, abstain from blood. As Jehovah's Witnesses, we view this and other similar Bible verses as a straightforward command from God. It is a rule set from Him to us. Of course, the Bible is not a medical text, and so this command is not stated in medical terms. However, Jehovah's Witnesses view this as ruling out blood transfusions. At the same time, we understand that modern science has made it possible to separate blood into various fractions and components for use in medicine. So what exactly does this mean for Jehovah's Witnesses and the clinicians who treat us? As we can see here on the left side of the slide, Jehovah's Witnesses do not accept whole blood. Jehovah's Witnesses would also not accept the four main components of blood, and this is red cells, white cells, platelets, or plasma. However, if a Jehovah's Witness wanted to accept any fractions or derivatives of these four main components, that will be a completely personal decision. And that explains if you see a witness patient to accept using a fraction and someone else no. This personal decision, of course, would have an effect on the treatments a witness patient could accept. And as you are all aware, many modern medicines are developed using fractions of these four main components. Some examples of common medicines that contain derivatives of those four components are albumin, immunoglobulins, clotting factors like fibrinogen, tranexamic acid, the one who was used in the case Paul referred earlier. But what is our position on autologous procedures? As you see in our next slide on the right, preoperative autologous donation is not acceptable to Jehovah's Witnesses. On the left, you see autologous procedures that are acceptable, like the self-salvage machine or a dialysis machine. Using those procedures is a completely personal decision. And again, that explains why a witness patient may accept a procedure and another not. So we all understand, and we want to emphasize this point here, how important is good communication, both when it comes to use fractions or autologous procedures. The good communication is needed so that both the patients and the clinicians involved feel comfortable with any prescribed treatment. In fact, because we understand the need for good communication, we have a tool that will assist you in better understanding our position regarding medical treatments. Something that is very, very helpful, especially if a patient is unconscious. And this is the Durable Power of Attorney or DPA card. It looks like this, but usually you will find it folded in a packet, in the wallet, in the jacket, on the person of a Jehovah's Witness patient. And as Jehovah's Witnesses, we make sure that this card is on our person at all times. This is a legally binding document, and it directs that no blood transfusions are to be administered to the patient under any circumstance. In addition to this, inside the DPA indicates the individual's appointed healthcare agents who are authorized to make medical decisions on behalf of the patient if the patient is unfortunately incapacitated. Isn't it an excellent tool? It helps you to immediately know the patient's health decision and points you to the correct people to contact if they are unable to make the decision themselves. So then, in review, in this section, what we examine: that Jehovah's Witnesses endeavor to find quality medical care, but without blood transfusions. This is an informed choice based on deeply held religious convictions. We also value good communication between the clinician and the patient. And along with that good communication comes the ability to develop individualized plans that use alternative treatments that are acceptable to the patient. To speak a little more on this, we call Paul to discuss the next section, strategies.
So then, thank you, Evan. What strategies can be employed to optimize blood and avoid blood transfusions? This question will be answered under this section. So what fundamental principles can help you as clinicians to treat a witness patient? It has been well established in the literature that bloodless medical care is safe. Other doctors have paved the way to show that outcomes are equal or better. To achieve this, however, an organized approach is necessary. And we can see from the following strategies how this can be done. First, it's minimization of blood loss. Some possible strategies that have worked are restricted phlebotomy. In other situations, it may be meticulous and prompt surgery. In addition, the use of pharmacological agents like tranexamic acid are often a consideration. Second component, enhancement of hematopoiesis. There is a need to rebuild what was lost. Here, some possible strategies that can be used are erythropoietin or IV iron. Could be vitamin C or vitamin B12, some folic acid. A third area is tolerance of anemia. This is where judicious fluid replacement or supplemental oxygen support can be used. And we know in the Centenary campus, there is a hyperbaric chamber, and that has been used on Jehovah's Witnesses. The fourth is autologous blood management. As Evan stated before, some witness patients accept the use of the cell salvage machine or acute normovolemic hemodilution. But these strategies can be most effective when used in multiple combinations, focused on the patient. As you know, blood is a finite resource. It has been called the only liquid organ in our body. To protect this resource requires us to acknowledge that everyone has a limited budget of blood that needs to be saved. Fortunately, with these strategies, we can save this organ without having to break the bank. For example, how much blood can be saved by implementing a combination of these strategies? Let's take, for example, the surgical patient described by Doctors Goodnow, Shander, and Spence in the article, Clinical Care Without Allogeneic Blood Transfusion. There, they describe a surgical scenario where at least 8 units of blood can be saved. Preoperatively, for example, tolerance of anemia can save 1 to 2 units. Increase of preoperative red blood cell mass, 2 units. Interoperative, with meticulous hemostasis and operative technique, 1 or more units. ANH, 1 to 2 units. Blood salvage, 1 or more units. And then there's postoperative. Once again, the blood salvage, 1 unit, or restricted phlebotomy, 1 unit. To manage the witness patient successfully, it is crucial that clinicians implement not only a multimodality approach, but also a multidisciplinary approach. Why though? Well, we'll go back to Evan's favorite game, baseball. When the Los Angeles Dodgers recently won the World Series, we know more than just the players were necessary. There was an entire team behind the scene, each with their specialty, ensuring players are optimized and ready for the day of the big game. So too, implementing an organized multidisciplinary team approach to developing an appropriate blood management strategy ahead of time is vital to ensuring patients are optimized for surgery or treatment. The early involvement of hematologists to optimize red blood cell mass and to address anemia, making sure that the patient blood management office is used early. In addition, advanced consultation with anesthesiologists to plan for autologous blood management. For example, will all the necessary equipment be available? Or if things don't go according to plan, what are the backup plans? It's that group effort that leads a team to victory. While on that subject, when dealing with a bleeding witness patient, why should clinicians avoid a watch and wait approach, even if the patient is very anemic? Well, we can see that time is blood. In one study of actively bleeding Jehovah's Witnesses, initial conservative treatment with delayed surgery led to a 75% mortality rate compared with a 20% mortality rate in patients who underwent emergency surgery within 24 hours of admission to the hospital. Regarding prompt intervention, one doctor states, a focus on hemostasis and resuscitation, instead of attempts to convince the patient to accept blood transfusion, can be life-saving in patients with acute bleeding. So what can the result be when these strategies are adopted on a large scale? The Western Australia Department of Health ran a comprehensive health system-wide patient blood management program. An observational study in 4 major adult tertiary hospitals found that this program was able to reduce the transfusion of red blood cells by 41%, plasma by 47%, platelets by 27%. What you see on your screen is the results of these reductions. There are also case studies, and here are a few examples of complex case studies that have been successfully treated without blood. There's some on hematology, oncology, critical care. For internal medicine, it's gastroenterology. And here is one case study that for management of anemia in patients who decline blood transfusion. Therefore, in summary, under strategies, what did we understand? That the combination of multiple strategies with a team effort can achieve the best results, even in complex situations. However, there is another resource available to you that we would like to end on. Evan will now discuss our third and final section, the network.
Thank you, Paul. So what is the Hospital Liaison Committee, HLC, and how can utilizing our network make your job easier? The HLC keeps the focus on the medical care required by the patient, not on the refusal of blood. However, HLCs are only one part of our support network. Hospital Information Services, or HIS, is a worldwide network. It is located at the world headquarters of Jehovah's Witnesses in Warwick, New York. But the network is not only in North America. It operates on 6 continents. There are 86 branch offices that have an HIS satellite office. And we are happy to have one of those here in Toronto. There are over 2,000 HLCs operating globally. There are 50,000 volunteers who serve as HLC members or who are part of the patient visitation group or who work at the 86 offices. And of course, we are so thankful for your assistance. There are over 100,000 experienced clinicians who are cooperative and consulting doctors, the majority of whom are not Jehovah's Witnesses. And that includes some who work at Scarborough Hospital itself. This HIS network not only functions worldwide, but is also available to us 24/7 to assist clinicians and patients alike. Let's focus on one aspect of our network, the HLC committees. Each HLC member is a community-based minister, and our role is to assist Jehovah's Witnesses patients and the clinicians who treat them. Our role is not to police, make decisions for, or impose our personal views on patients. Rather, at the personal request of the patient, we support the patient's desire to receive high-quality medical care without allogeneic blood transfusions. HLC members also help patients interface with clinicians and hospital personnel, social workers, and members of the judiciary if is required. In Canada, we have 1 HAS and 17 HLCs across the country. But more specifically, here are 4 main ways we assist. The first way is by offering presentations just like this one. And these help because they provide a better understanding of our beliefs. Also, it allows for clinicians to ask questions, as you will have the chance at the end of the presentation. And we are more than pleased to hold these sessions. We can do it virtually as we do today, or in person. We have held presentations with small or large groups, or even in one-on-one settings. And at this point, I would like to say, if you are aware of anyone that would be interested, but it wasn't invited here today, please let us know and we'll be very happy to arrange a presentation with them. And by the way, keep in mind that if the audience is from a specific specialty, then the strategy section we had can be even more individualized for that group. What is the second way that an HLC can help? The second way is so invaluable, is consultation. Our national office keeps a list of doctors with experience in treating witness patients without blood transfusion. These doctors are willing to consult. Many of these write articles or lecture on the subject. And this amazing resource is available 24/7 and internationally. So how to benefit? At the end of the presentation, Paul will play a slide with our contact and our hotline number. So please feel free to call us or straight to the hotline, and we'll be more than happy to arrange a consultation. What is the third way we can assist? This is support. HLC members not only help clinicians to understand witness patients' point of view, but also help witness patients to understand the clinician's concerns. So we encourage good communication between clinicians and witness patients. In addition, pastoral care and practical assistance are provided. And again, with this opportunity, I would like to thank you for taking advantage of the Patient Visitation Group, PVG, arrangement in Scarborough hospitals. And there is a fourth way an HLC can help, and this is resources. We provide peer-reviewed information for managing patients without blood transfusions. And this includes clinical strategies, medical articles, and selected citations. Whoever is interested, we have this set of strategies in hard copy, and we can distribute it to each one of you. So please, let us know at the end who would like to have a copy, and we can bring it to you. In addition to this, there is a super helpful resource for clinicians, and this is our Medical Information for Clinicians website, which is available in 31 languages. This website, where thousands of clinical references are located, this bypasses the religious part of our website and goes directly to the medical information you will find most useful. Would you like a demo? Let me change my sharing my screen. So let's say that you scan the QR code you see on your screen. It will pop out this website. Here, as you see, there are information packets organized by specialty. For example, if you click internal medicine here, it will give you the option to download as a document the information, or you can share the download link with others. It's very easy to use. And let's turn to the slides here. So those were the 4 ways HLC can help. And we really hope you take advantage of those 4 amazing tools. But while these are all good tools, what is the key to treating witness patients? How can we find patient-centered solutions that avoid the use of blood? The key is having good collaboration, where the patient is in the middle. Don't you agree? The patient is the key person. Whether it's the HLC, the administration, or the clinicians, we want to collaborate so that the witness patient gets the quality medical care they are looking for. The HLC and clinicians can collaborate to identify acceptable clinical strategies. Clinicians can take advantage of the patient blood management office that exists in Scarborough Hospital and its protocols. The administration can, with the HLC, can work together to ensure that spiritual care is provided through the PVG arrangement. So we truly hope that we can continue work together on these issues with you all. In review, for this section, the network, we have seen that the HLC network is there 24/7 to assist both physicians and witness patients. And that collaboration is the key to achieving the most optimal outcome. Please use our network to the most. It will certainly make your job easier when treating witness patients. Arrange presentations, consultations, access our resources. Visit our website, call us individually or our hotline whenever you need. Now for the review and the conclusion, we go back to Paul.
Thank you very much, Evan. In your review, in this presentation, we have analyzed 3 keys to collaboration. Section 1 was prepared to help you understand our position. Section 2 was prepared to provide you with information regarding the implementation of clinical strategies to avoid blood transfusions. And Section 3 was prepared to help you to utilize our network and benefit from it. So this concludes our presentation. We will post our contact on the final slide. And as Evan said, please feel free to contact that toll-free number. It's manned 24 hours a day, 7 days a week. And this concludes now our presentation, and we can open the floor to any questions you may have.
Hi, yes, I have a question. I put in the chat, but the slide that I just needed a clarification. The slide regarding blood salvage being acceptable and autologous blood transfusion not being acceptable. I just wanted to know the nuance behind that. In terms of, is it a matter of the fact that you're donating ahead of time and that's forbidden, or I'm not sure. I just wanted to clarify that.
So just to clarify that question, that's about the autologous
Yeah,
the
so
cell salvage.
that slide that on the right hand side, it said autologous blood transfusion was forbidden, but blood salvage was acceptable. So I just wanted to know, I just wanted the clarifications to, how Jehovah's Witnesses view that as different from one another. I mean, it is different in terms of the processes, and I'm just wondering what part of the process makes it forbidden.
Yes, that's a very good question. And you're right that Jehovah's Witnesses, we do not accept preoperative autologous blood donation. However, autotransfusion techniques, such as hemodilution or the cell salvage or the blood, the blood salvage, it's a matter for personal decision. And that's where it is. It's a continuous position. So at that moment, when that machine is used, Jehovah's Witnesses may accept it. I don't know if, John, you have any other
Yeah,
information?
thank you, Paul. This is a very good question, as you mentioned. So with cell salvage, it's been very, very helpful with witness patients. As Paul mentioned, it's a personal decision whether it's used or not. One of the main things is that it must be primed with a non-blood product. So the use of cell salvage is with the person's own blood. If they personally decide that they would like to have it used during a procedure, then the witness patient actually views it as an extension of their body during that procedure. So it's unlike pad where the blood is actually bagged and taken away and stored. That's unacceptable to a witness patient. But cell salvage, hemodilution, heart-lung machine, long as they're all primed with a non-blood product and the patient personally decides they would like to have it used during a procedure, is perfectly acceptable. And in fact, has been very, very useful in many procedures.
Thank you.
So I think it looks like everyone seems satisfied, and I don't see any other questions or hands up. Again, I'll take note of this information and just want to thank everyone presenting today for this useful information. I do agree that often, I think there's some sense of challenges, I guess, faced. Most of the times it's more of just trying to realize, again, wanting to help the patient, but also not wanting to sort of cross any lines that the patients have. So I think the resources that you presented to us for our use and the points that you made are very important. So again, I think that having this information as a resource will be very helpful in the future.
Well, thank you very much. We thank all the clinicians that are involved in the team effort, and we appreciate your help once again. We really appreciate that you're our community hospital and you're a clinician. So thank you so much.
And thank you once again.
Thank you. Okay. I guess there is no other question to answer. Thank you all for participating at the presentation and everyone who was attend. And we look forward to see some of you in person and keep contact with you. We can stay a few minutes in since we have some connections in case someone wants to ask something.
I think we're going to take the afternoon off and then start fresh tomorrow morning.
Good decision.
I think so.
You stay close or you drive?
No, we're staying at Cambridge Suites. It's about 15 minutes from the hall. So it's been quite handy to be there for 7:20 in the morning. Especially this morning, it was tied into Warwick. So it's good to be there that early, and that would take an hour, 3/4 from home. So it's a little nicer at 15 minutes instead.
Of course.
Mm.
You work so hard.
It has been a few muscles I don't normally use.
Now let me know what the treatment for that is, Rosie.
Well, I did book a hotel with a hot tub, so
Well, that's a good solution.
Yeah. But it's encouraging that the 20-year-olds, 20 some odd olds that are with us are complaining just as much. So it's not just us old creaky bones.
That is encouraging, Rosie.
But
Well,
then again,
thank you both for your hard work on that.
it's been such a joy.
Yeah.
I guess ripping out chairs and smashing up expansion bolts out of concrete is not something too many people normally do.
No, that's not a daily normal activity.
Yeah. Today was taking down T-bar ceilings. So that was a little easier. It was just a lot of bending and stretching, picking up the panels, but the auditorium looks very different than it did before, that's for sure. Yesterday, I guess about the front, well, not half, but quite a bit of it, no longer has chairs. Let's see if I can find a good picture. We even ripped up the rug so that they can put down scaffolding.
What do you think? No one will join now, no?
I think, Evan, it looks like they're going back to their afternoon routine. So
Mhm.
Or maybe a few minutes for lunch before they go back.
maybe, yeah, in between.
Hmm.
Anyway, it was nice so many could join. That was encouraging.
Thank you for making the time, all of you, and being here. And we'll see you again soon.
Look
Sounds
forward
good.
to it, Evan.
Thank you.
Thank
Thanks, Rosie.
you. Thank you very much.
Thanks, Paul.
Thank
Bye,
you.
everyone.
Bye.